Hey everybody, welcome to our meeting today. I'm just really quickly posting an announcement. I made a video on the mouse party, which is about your brain on various drugs, how it affects the neurotransmitters and synapses and everything. So I want you to watch that. It's in the announcements, just mouse party video. So I'm just doing that really quick while everybody's getting in. So we'll just wait for a moment. Ugh. The video of your brain on drugs. All right, let's call it that. And so watch that at your leisure, but it will be really good if you watch it soon, before your exam next week. Let me put it in the other one. I know, just what you wanted to watch is me typing. Second. I have uploaded more stuff to Canvas in the past month than probably in my whole life. Okay, boom, so they're there. All right, so let's go ahead and get into what I want to talk about today, and we're going to start the peripheral nervous system. Oops, I don't want to do that yet. So let me share my screen, and away we'll go for today. All right, where's my, there we go. Okay, so peripheral nervous system and reflexes. All right, so what is our peripheral nervous system? So remember, this is the part of our brain that's going to be the nerves. Okay, so and nerves, and then out in our, away from our central nervous system and everything that has to do with them. Okay, so we've got two divisions to our peripheral nervous system. We have the sensory division, and so it's going to involve all of the senses that we have. So somatosensory means senses of our body. So they're going to be the senses of temperature, touch, pressure, and pain. Primarily those things we find in the skin, but of course it's not just our skin that we can feel touch, pressure, pain, temperature with, but all throughout our body. Okay, and then we have our special senses. So we have hearing, we have balance, we have sight, smell, taste, and I hope especially now that we have a sense of humor. Don't really have receptors for that, and as you know, everybody's got different senses of humor. And oh, I didn't do Mike the Chicken for today. Okay, well, I have to, thought I could throw away that list, but not. Okay, so we might not all have the same receptors for humor. I don't even know what funny, how we can, what humor really is, but I'm glad that we have it. And I hope that we are able to find it in these perilous times. All right, then the motor division of the PNS, or peripheral nervous system, will be all of our motor neurons going to our skeletal muscles, and it will also be our autonomic nervous system, where the motor neurons are going to go to visceral or smooth muscle, and I don't know why I didn't put cardiac muscle on there as well, through what are known as the sympathetic and parasympathetic divisions. We will briefly mention those, probably won't talk more about sympathetic and parasympathetic until we do the autonomic nervous system, which is on the next exam, so that's not for next week. All right, so again, we look at the divisions. We can see here is our sensory input going through our sensory neurons to our brain, to our integration center, and then we'll have our motor output have to go through the PNS, through our motor nerves, and then our motor division is based on, and I'm going to go ahead and type those in just so that you can remember. Okay, so autonomic nervous system, this is going to be smooth, cardiac, muscle, and glands. Okay, so that's what's governed by our autonomic nervous system, and our somatic motor division is going to be just simply our skeletal muscle. Okay, So remember, autonomic nervous system governs the contraction of our smooth and cardiac muscle and the secretion of our glands. And then again, the autonomic nervous system can be divided into sympathetic and parasympathetic divisions, but we're not going to worry about that on this test. Okay. All right. So here is what's going to happen with our peripheral nervous system. So we're going to have sensory receptors out here. They could be free nerve endings. They could be an organ such as a muscle spindle. They could be a joint kinesthetic receptor, which are more complex. These two are more complex than just free nerve endings. But the sensory neurons are going to come in. Oh, look at, where are they going to go? Remember we talked about reticular formation. All of our sensory input is going to come up in through here. And now we're into the CNS. And so now we're going to send signals up to the thalamus, which we're then going to take it to our association, well, our sensory areas, and then our primary sensory areas, and then we would have our association area behind that to understand what we're feeling. You can look at if we're doing coordinated muscle activity, that we're going to send it to the cerebellum. We're going to send that sensory input to the cerebellum by way of the pons, even though it doesn't show, it actually goes through the pons to the cerebellum. And then, but it also lets us know what we're doing too. So we could, you know, be playing our Xbox or whatever. Our brain needs to know what we're doing, but our cerebellum will govern a lot of that movement that we're doing, the hand-eye coordination kind of thing. All right, there are different types of sensory receptors based on what are we trying to sense, what is the sensory input that we're trying to capture, the stimuli that we're trying to capture. So the first one are mechanoreceptors. So mechanoreceptors generate nerve impulses by being deformed. So if they're bent, if they're vibrated, if they're stretched, just however that you move the nerve endings, that will be a mechanoreceptor. So what kind of senses would we be using mechanoreceptors in? Well, in touch, obviously, because when you run your hand over something, when you're touching something to feel its texture, you're moving those nerve endings. And the degree to which you move them will let you know how rough or bumpy, or if they're not moving, how smooth something is. Pressure, if you push, excuse me, if you push on something and those endings are pushed away, again, you'll detect that as pressure. Vibration, I'm particularly sensitive to vibration. And I'll tell you more about that when we get into hearing and balance, but I'm super sensitive to that. And so I don't know, whatever's going on, my brain is very aware of vibration. Stretch receptors we'll talk more about in this chapter. Now, itch receptors. Itch receptors are really interesting. They're very, very tiny and down in your skin. And so when they're being stimulated, there's a variety of things that are going to cause their displacement, their movement. So if you think about what makes you itchy, so obviously like dry skin makes you itchy. So we'll talk about, well, why would dry skin cause that? Bugs walking on your skin makes you itchy. Itchy sweaters, textures that are going to cause a lot of displacement of receptors in your skin. Inflammatory chemicals like histamine, if you have a rash or hives. Okay, so what are you trying to do in every one of those? Well, not trying to do, let's come back. So how are they being sensed? So the itchier a fabric is, for example, the more it has an ability, you know, because it's pokey on a microscopic level, it's super pokey. So it can get into your skin and stimulate those itch receptors that are in there, and you don't like that pokiness in your body is just trying to protect you from that pokey nature. What about dry skin? Well, when your skin is dry, you get microscopic cracks in it, and then air will get in, and air will stimulate those itch receptors, and you don't normally have that. And so so now you're aware of it because you have dry skin. Histamine. So when you get hives, so you get a bee sting. Okay, so or not a bee sting. Let's take a mosquito bite, for example. So when the mosquito bites you, she injects this chemical in you to keep your blood from clotting so that she can suck up your blood. And when she squirts this chemical into you, it's not what causes the mosquito bite. That is your body's response to that invading chemical. And so your body will secrete a chemical called histamine that makes your blood vessels very, very permeable and a lot of blood flow to the area. And so in that area where that chemical is, that histamine is being released. And so you get a fluid buildup in there that's then going to push on your itch receptors. So in all of those cases, when you scratch, what you're trying to do is get that thing, that stimulus, away from your itch receptors. When you're wearing a scratchy sweater, you're trying to, you know, get rid of that feeling. And in addition, it's also like the dry skin idea. The more that you scratch, the more you secrete sebum from your hair follicles, and the more it will cover over those itch receptors so they won't be bothered as much. And then the itch with an inflammation, like allergic reaction or the mosquito bite, that's to disperse the chemical, to get that heparin-like substance that she squirted into you when she bit you. So I find itch, obviously, because I just spent 5 minutes telling you about itches. I find itch really, really fascinating. And then I don't know if you picked up on the fact, maybe you guys already know this, I don't know, but I said that I always refer to mosquitoes as she's. That's because the only mosquitoes that bite you are female, because they need blood in order for their eggs to mature. And so male mosquitoes don't have bitey mouth parts to be able to poke in you and suck your blood. So just thought you'd like to know that. And then sound, obviously sound is a vibration. And so you have receptors in your ear to be able to pick that up. And like I said, I'll tell you more about how all that works when we get into hearing after this next test. All right, the second type of receptors are thermoreceptors, which are sensitive to temperature changes. And what's really cool is that they're able to pick up degrees of change instead of just saying, okay, this is hot, this is cold, that you have every temperature in between, the most extreme you can stand on either end, the most hot you can stand and the coldest you can stand. Just temperature is amazing. I really don't understand how it works, but it does. All right, photoreceptors. Photoreceptors are going to respond to wavelengths of light, and we have photoreceptors that are just going to respond to light and the degree of light. So light and dark, those would be the rods, which are able to detect brightness and dimness, I guess, light and dark. And then we have special receptors called cones, which are receptive to particular wavelengths of light, because different wavelengths of light give us different colors. So our color perception is based on how our cones are able to pick up the wavelengths of light from colored objects. Again, we'll talk all about that when we get to senses. Chemoreceptors are those that are going to respond to chemicals in solution. And the thing is that the chemicals need to be in a solution. So let's take what chemicals do we sense? Well, things in taste and smell. And in both of those cases, they'll either be the things that we're tasting and smelling, the stimuli will be dissolved in our saliva, or they'll be dissolved in the mucus in our olfactory epithelium up in the top of our nose. Now, we don't just detect chemicals outside of our body, as in taste and smell, but we also have interoreceptors, which detect chemicals in our body. And that's how we maintain our homeostasis for various chemicals in our body, like sodium levels, potassium levels, chloride levels, glucose levels, hydrogen levels. Okay, so we have exteroreceptors, which are going to detect chemicals outside of our body, and interoreceptors, which will be the chemoreceptors that detect things on the inside of our body. Now, nociceptors are really important because these are ones that are going to be our pain receptors that will respond to potentially damaging stimuli that result in pain. And I don't really even understand how that works either, but I'm glad that I have them because I don't think we can even imagine what life would be like without pain. Now we think, oh, that would be fabulous. But if you can't sense pain, then you can't protect yourself from danger. So, for example, I had a lot of students used to work in the ER years ago, and at the time that they were working, there was this boy that lived in the area, and he was born without pain receptors. And so he would come into the ER all the time with a laceration that needed to be sutured, or with a broken bone or something, because he couldn't feel what he was doing was actually harming him. So he would end up doing activities that would result in an injury that then needed to be treated. And pain is so protective for us that, like I said, I cannot imagine having, life without pain. I just don't want chronic pain. I'm not a fan of acute pain either, but I'm happy that I have it when I have it, if it's protecting me. And then proprioceptors are going to respond to stretch and skeletal muscles, tendons, joints, ligaments, to be able to determine body movement and position. So that's like, so I'm just going to show you how this works, because I can't do it other ways that I normally demonstrate this. So let me scoot back here. So here's how proprioceptors work. So you can try this at home, put your arms out to the sides, and then I want you to touch your nose with your eyes closed. Okay, touch your fingers in the center. Okay, those kinds of activities where we're not using sight to tell us where things are. It's the position, the stretch in our muscles and in our joints that lets us know where our limbs are, so that we can, touch our noses without seeing where our fingers are. So that's proprioception. But proprioception is also going to help us keep our balance. And if we were here, we would be doing a lab on reflexes next week. Yeah, next week. And so we would be testing different reflexes, and we'd also test your balance reflex, where you would stand with your feet together. And you can try this at home. This actually might be fun to do with your little family, whatever, children, brothers and sisters, I don't know. And so stand in the middle of the room with your eyes closed and your arms at the sides, and then see how long it takes. I'm not going to do it. See how long it takes before you start to sway. And then see which direction do you sway. And the reason why you're swaying is that your body doesn't know where it is in relation to gravity. And so it's just letting the muscles relax. And so as they stretch, as you start to move, follow one direction, and start trying to keep your eyes open and seeing where you need to be, then it stretches and you go, oh, okay, now I'm moving backwards. And so then you relax to go the other way, and then you have to contract those muscles to help keep your balance. And so the degree that you sway and which direction you sway, that's proprioception. But you have to do it. If you do it, you can't stand with your legs shoulder width apart or even hip width apart. You have to stand with your feet together, because when you're standing in an unneutral position, so with your feet apart, then that stabilizes you as well. But you have to, so stand, eyes closed, anatomical position if you want to, but with your feet together, and give that a try. Okay. All right, so those are our different sense receptors, and then this just shows what they can look like. Now here's, this has to do with the reticular formation that we talked about, and the thalamus, and how we need to, all that sensory input is going to come in, but we need to filter that sensory input out. That the input that we're already aware of, that doesn't matter, that we don't have to pay attention to it anymore. And that's called adaptation. So this is a reduction in sensitivity and nerve impulse generation in the presence of a constant stimulus. We're going to get inhibitory neurotransmitters being secreted, because I don't need to always be aware. So I'm just going to do this, and And whoops. I don't need to be aware of the fact that I have a hat on my head all the time. And now I can feel my bangs on my forehead and my earrings because I'm aware of them. I'm talking about them. But, you know, think about your parents, and because your parents are about my age, maybe a little bit younger, and how many of them go, oh, I can't find my glasses, and they're on top of their head because they put them on their head, and then they didn't need to be aware of the fact that they were on their head anymore because it wasn't affecting their survival. And so then we adapt, we stop sending those signals, and then we can't find our glasses. And I bet every single one of you at some time in your life has wondered where your phone was, and it was in your hand you don't write with, okay? Because we do that. We're just like, I'm carrying, you know, whatever. The worst thing that's happened to me, and I hate to admit that I'll be doing something on my phone and I'll think, where's my phone? I need to do something else. I mean, that's the worst. But I'm old, so I guess that's why it happens. Okay. So let's go back to that. Fortunately, as my voice cracks, fortunately, hearing and smell and many of our touch receptors adapt really quickly, so that you may have a hum. And I talked about this yesterday or on Wednesday, didn't I? You live by the railroad tracks, right? And then the train goes by in the middle of the night and you don't even notice it anymore. That's adaptation. You have gotten used to that because, and what does used to that mean? It means that those nerve impulses are not being sent as much anymore. We are inhibitory neurotransmitters like GABA. Smell, yeah. You know how when you walk into somebody's house and it has a smell? I mean, it doesn't have to be an odor. It's just, you know, there's a smell. And then people that live at that house are like, I can't smell that. I don't, you know, because that they're used to that. That adaptation is kicking in. They don't smell it all the time until maybe they go out and they're gone for some time and they come back in. They're like, oh, I do get that smell in my house. Okay. Burnt popcorn from the microwave, you know, all of that. And then touch receptors again. I don't always want to be aware of the clothes on my body because that sensory input might drive me mad. And that's, some people do not have adaptation, and that's why they have that sensory overload disorder thing that I know has a name. I can't remember what it is. And so they have to either learn, or we have to reduce the amount of sensory input that they get. But that can be very nerve-wracking. But pain and proprioceptors do not exhibit adaptation. Pain, now we can tolerate pain and we can take medication for pain, but pain will never like entirely go away. Those sensations will still be sent. And then proprioceptors, because we don't want to not be aware of the pain, because then we think, oh, I can do something. You know, that's why I'm not a super fan of cortisone shots, because cortisone reduces the inflammation to the point where the pain receptors aren't being stimulated anymore, but you still have an injured joint. Like I have a super bad shoulder and it hurts all the time. And I'm really tempted to go and I'm thinking to get an acupuncture first. That's what I like to try that and see, but I'm still a little leery about that because my shoulder is injured. And it's not like super injured. It's just a lot of scar tissue and stuff in there that doesn't want to move around. I have bursitis and so it's probably good that I have that pain in my shoulder so that I don't overdo it, that maybe I have some tendons and ligaments in there that really don't want to endure everything I want to subject them to. And maybe I shouldn't. And if I take away the pain, I might overdo and I might sustain a more serious injury than what I have in my shoulder right now. I mean, it's just being old. I have an orthopedic surgeon friend I grew up with, and he says, Tam, we're just old. There's nothing we can do for your shoulder. And I'm like, because I don't have a rotator cuff tear or anything, you know, really bad. It's just wear and tear. You're just old. It's like arthritis in my knees. I probably have arthritis in my shoulder too. But anyway, so enough about the pain. Okay, but then proprioception. What would happen if our proprioceptors adapted and we didn't get signals anymore? We'd fall down. So we would lose our balance. So we don't want our proprioceptors to adapt either. All right, so what is a nerve? We already know what this is, but we'll look at it again. It's a cord-like organ, part of the PNS. Bundles of peripheral axons covered with an endoneurium, perineurium, epineurium. We looked at this in lab a couple of weeks ago. So here's a cross-section through a nerve. We can see, oh, we've got blood vessels in nerves. A lot of times we think nerves are just tiny as hairs, and maybe they are in diameter, but there's still a lot of structure in those very microscopic organs. So we got nerves in, blood vessels in there, and then we have the individual neurons. So they would be all the yellow things. So these are all axons. There's no cell bodies in here either. These are just straight axons. And then they're going to be surrounded by the myelin sheath. Okay, so here's our bare axon. There's a myelin sheath surrounded by endoneurium. Then we're going to cluster those axons together in bundles called fascicles. Where's my there's fascicle. And then we're going to create a fascicle with perineurium, and then we're going to bundle the fascicles together in epineurium with some blood vessels down the middle. Okay, so we got that. All right, now nerves can be of three types. They can be sensory only, they can be motor only, or they can be mixed. So sensory nerves are going to be ones that just have sensory neurons in them. And because they're sensory neurons, they'll just carry nerve impulses toward the CNS, only sensory neurons. We can also call them as afferent nerves. And in a spinal, oh, we didn't finish spinal cord. I'm gonna go back to spinal cord in just a minute. As soon as we finish nerves, I gotta go back and look at our spinal cord notes. And that you didn't remind me. The roots enter the back of the spinal cord. So I'm so glad I saw that. So we're going to do that as soon as we finish this. And then motor nerves, nerves that carry impulses only away from the CNS, consist of only motor neurons, efferent nerves, and leave the front of the spinal cord. So I'll get to that in a second. And then mixed nerves are nerves containing both sensory and motor fibers and transmit impulses to and from the CNS. Okay. So let me leave this. Gosh, dang it. And stop sharing and find my spinal cord video or notes. We already know most of this information anyway, but because we did it in lab, but we're going to do it now in lecture. Okay, so come on. All right, so here is our spinal cord major reflex center of the CNS. So what does that mean? Well, it means that we have sensory input come in and motor output go out without any of the influence of the brain. And so we're going to look at that on Monday. Yeah, on Monday, we will take a look at how our reflexes work without our brain, because it's kind of a cool thing. So that's what we mean. It's just sensory input, motor output without influence, without thinking about it per se. Okay, surrounded by an epidural space between the bony vertebrae and the meninges. So epidural, so epi means outside of the dura mater, so it's the space between the vertebrae and the meninges. Like I said before, a couple of times, spinal cord ends at L1, so at the level of the first lumbar vertebra. We have no more solid vertebrae, solid spinal cord, and then it just becomes nerve roots, and we call it cauda equina because it means horse's tail, because it looks just like a horse's tail. Please remember this, there are 31 pairs of spinal nerves that exit through the intervertebral foramina, and I'll show you how that happens in a second. Remember in the spinal cord, gray matter's on the inside, white matter's on the outside. We have ascending and descending pathways we'll look at in a minute. And then it also has that central canal left over from the neural tube. So the opening in the neural tube has fluid in it, CSF in it, so it's lined with ependymal cells. Here is a coronal section from the back, a posterior view of how the spinal cord is organized. And notice that, green will work. Okay, these nerves coming out of here are between, so here would be part of a vertebra, here would be part of a vertebra, that pedicles actually, but you don't know that. And so here is the nerve coming out. So the nerves are coming out through these openings, the intervertebral foramina. or one would be an intervertebral foramen. Okay, so there's them coming out like that. Okay, here is L1. So we would stop our spinal cord. Well, actually, we'd stop our spinal cord about here. So conus medullaris is the end of the spinal cord. Here we have our cauda equina. And then we're going to have the pia mater running down the middle, called the filum terminale. And then we just have all these nerves coming out like a horse's tail. And so here it is in this picture, all of these nerves coming out of there. Okay. We saw this here is, actually we are not in the epidural space. That's this space right here. We are actually into the subarachnoid space where that hematoma was that we looked at. Here shows the spinal cord. So here's the gray matter, central canal. Here's all the white matter. Now, this is what I was talking about with the nerves. We had dorsal roots and ventral roots. And what does that mean? So let me go to the next picture. Oh, I kind of like this. Let's stay here for a minute. Okay, so here is here's the dura right here. So this all right here is the dura mater. And then we have the arachnoid mater, super thin right here. But remember, it's got these little extensions that come down. So here is that subarachnoid space. Did we put there we go, subarachnoid space. There's the subdural, actually, so subdural. So I guess maybe that hematoma, if it was in fact subdural, filled in that woman's brain here, and she still had arachnoid on her brain. I don't know. Anyway, and then here's pia. That goes down in here and touches there. So you can see the 3 layers of the meninges. All right, so now what I want you to look at is here's my nerve. So my nerve has got stuff going in and coming out because it's a spinal nerve and they're mixed. So they have both a sensory component and a motor component. So here is the sensory part that's going in. So it would come in this way, and then motor would come back out. Oops, I didn't draw that very good. Come back out. So there's a dorsal root and a ventral root. And we're going to look at it in this next picture because we can see it better in this next diagram. Okay, so so what's going to happen? Let's make our colors. All right, so sensory is blue. All right, so we've got on this side, and I think we already did this in lab. So we have sensory input, we have sensory neurons, and we have their little cell bodies all collecting in the dorsal root ganglion. And then they would come in through these dorsal roots, and then they would come to here, to the gray matter, and then they would synapse with an interneuron that would then go down to the ventral root, or the ventral horn of the gray matter, and then it would synapse with a motor neuron that would then go out through the ventral root. Okay, so there's the ventral root on the front, and then the dorsal root here in the back, and then together, then they come together, and we'll make it purple since red and blue make purple. So then this is mixed. This is mixed. This is mixed. Okay, so our spinal nerve has both a ventral side and a dorsal side with the sensory input and a ventral side with the motor output. So this is sensory input, this is motor output. Okay, so that. This just also shows how that works. So sensory input here is the dorsal root ganglion, where we have the cell bodies of the sensory neurons. Remember, cell bodies of motor neurons are going to be found in the gray matter of the spinal cord, and just their axons are going to go out. Okay. And we'll have somatic ones, and then we'll have autonomic ones. The autonomic ones are yellow, the somatic are the red. So this is voluntary, this is involuntary, smooth muscle, skeletal muscle. Notice also, so with referred pain, we have somatosensory, visceral sensory input, and they all synapse in the same place. So when you're having a heart attack, the neurons from your arm are coming into the blue part, the neurons from your heart are coming in from the green, and so your brain doesn't know exactly where is the information coming, and so it thinks it's coming from your right arm, I mean your left arm. Okay. Now this shows the ascending and descending tracks. So remember, sensory is blue and motor is red. And so if we look at what's happening here, this is our sensory input. So our sensory input's coming in here, or it's coming in here, and then it's going to go up to your brain. And so all of these places will be sending signals up to your brain. Okay, and then all of these other places will be sending signals out. Okay, so they'll get stuff input from your brain, from your motor neurons coming down through the gray matter, and then they will then go out through, ooh, I didn't draw that very good, out through the ventral root and then out through the nerve. You don't need to know the different tracks. Just know that we have the blue ones, sensory input, and the red ones, the motor output. The next few slides just show some examples of the sensory input coming in. So here we have the muscle spindle, so proprioception. For our balance, we just need to send it to our cerebellum for our hand-eye coordination. So here's our sensory input in this blue going up to our spinal cord, and then boom, going to the cerebellar cortex, I guess, the gray matter of the cerebellum, so that we keep our balance. And then to know that something's tickling our foot, that has to go all the way up to our parietal lobe. So then it'll come up here, go up through the back, go up and up and up and up through the white matter, and then it go to the thalamus. Look it right there. All sensory input goes to the thalamus and then goes to the appropriate location on our parietal lobe. I love that picture. Now, how about motor output? Does the same thing. So the motor output's going to start, let's say I want to move contract my elbow, contract my biceps, bend my elbow. There we go. So I'm going to start my thought to bend my elbow will come out of my frontal lobe, and then it'll go down through my gray matter, through my cerebropeduncle, and that's in my basal nuclei. And then it'll go down through my pons, and then just below that, it's going to cross over to the other side to get it to contract. And then here was my this side going to, okay, so I'm bending my elbows at the same time. And then this crossed over to the other side and went over to act on that. So my left side controlled my right side, and my right side controlled my left side. I love that. Okay, and then this is a myelomeningocele. So this is spina bifida, where the back skin and muscles did not cover over the spinal cord. So this is the dura mater here on the outside, and you can see that little lesion right there. Inside of here would be spinal cord for this baby. So this is probably a super old picture that they didn't detect it in utero during an ultrasound, and so the baby was born with the spina bifida, and so then they would have to hurry up and do repair immediately before the baby even went home. They'll do some repair. They'll just tuck the spinal cord back inside and cover it up. Like we saw in the repair video, they would do the thing, you know, postnatally, but a lot more potential for damage has happened because the baby went full term without treating this myelomeningocele, and so it'd just be interesting to see, you know, what were the effects on that little baby. All right, so that's that. All right, so let's go back to my other PowerPoint. All right. And share that. All right, oops. Okay. All right, so make sure that you know in the spinal cord, that with the spinal cord, all of the nerves are mixed. So all 31 pairs of nerves associated with the spinal cord have a sensory input in the dorsal root and a motor output in the ventral root. So they are all mixed nerves. Okay, Ganglia, we know this already. Dorsal root ganglion, collections of nerve cell bodies outside the CNS. Sensory neuron cell bodies are found in the dorsal root ganglion. Now, in our autonomic nervous system, we do have some ganglia. So we do have some motor neuron cell bodies in ganglia, but you're not going to need to worry about that right now. So just know a ganglion is a collection of nerve cell bodies, but you need to know the sensory neuron cell bodies are in the dorsal root ganglion. So that one you need to know, but autonomic we'll save for when we do the autonomic nervous system. All right. So here's the deal. You're out there in the world and you get a really bad laceration. Okay, I'll just, instead of using you as an example, I use a real example. So I had a student, which is how I always preface everything. I had a student that used to do parkour. So that's, you know, gymnastics out there on buildings and stuff like that. And so he had a team that competed together, you know, against other parkour teams. And he had gone to a competition. He wasn't competing in this particular competition, but he was just training with his teammates. And so he was doing this one stunt that required him to put his hand up against a plate glass window. So he put his hand against the plate glass window, and the window gave way. It broke under the force of him pushing against it. And as a result, his wrist came right down on the jagged glass, and he cut everything in his wrist. All the nerves, all the tendons, all the blood vessels. So they hurried up, you know, got the bleeding stopped, rushed him in to surgery to put as much together back as they could. And so he got they got all the tendons sewn back together again, any ligament damage, blood vessels sewn back together. And they were even able to reconnect the nerves so that he regained full motion in his hand. The nerves to his thumb were the ones that took the longest to regenerate, but about 9 months after the accident, he had full mobility in his hand. You know, similar to the guy with the rock. I mean, he had injuries too, and they were able to restore most of his function. Not, you know, the strength, but we're able to restore the function. Like he said, I can clearly type. So how is that possible? I thought, you know, if you destroyed a nerve, then that was it. As long as the cell body is intact, and in most cases, the cell body is either within the central nervous system, so protected by bone, or it's very close. The ganglia are very close to the cell body, I mean, to the vertebrae. So we're fortunate we don't get a lot of damage, but if you had a broken neck, for example, and you damaged the spinal cord material, so the gray matter in the spinal cord and the cell bodies were damaged, then that's it. Then those nerves are done. And so that's why with broken necks, we often get paralysis and different degrees of paralysis, is because we've damaged the cell bodies. But in Anthony's case, he was able to grow back, or the axons were able to grow back because of this. I'm going to show you the picture first, and then we'll go back to the notes. And then that's where we'll stop, because we're going to get into cranial nerves, and we'll just start fresh with cranial nerves on Monday. Okay, so here's what's going to happen. So you've got some injury. So here is the site of the nerve damage. The axons have been destroyed. We've got some myelin that's messed up. We've got some Schwann cells that are broken. Okay, with some endoneurium outside of here. So here's what you're, and then if you look in cross section, here it is. So here's what's going to happen. So in step B, as long as you have Schwann cells intact, the Schwann cells will reproduce themselves, and they will start growing back around where the axon used to be. Now, macrophages will come in and clean up all of the neuronal debris, so the axons that were damaged downstream, so distal to the injury. Here is the intact myelin, intact Schwann cell body right there. And so the Schwann cells grow over. And now if we go to picture C, what we have is known as a regeneration tube. So the Schwann cells have grown into a tube that will allow the axons, they'll sprout, these little sprouts or filaments trying to find where should they plug back in again. And once they plug back in again, then we've got the one single enlarging axon filament, so just the regular axon. The myelin will be surrounding the axon again. Here's the neurolemma from the Schwann cell bodies, and then here's the endoneurium around it. So it can grow back. If just the axons are damaged, then they can grow back. So if the cell body remains intact, severed axons can regenerate. Distal to the injury, axons are disposed of with the neurolemma, so that's essentially the regeneration tube. That's the cell bodies of the Schwann cells, not the part that wraps around, but the part that's left after they wrap around the axon. So then the Schwann cells, because those cell bodies are still there, the nuclei are still there, so they can reproduce themselves and form the regeneration tube. Axon sprouts develop, pass through the tube to their original sites. Axons can regenerate at a rate of 1.5 millimeters a day. Now that's the width of a hair. So, I mean, actually width of a dime more, so a few hairs. But CNS fibers never regenerate. So we don't really get in stop stuttering, Phineas Gage's case. So because most of his damage was in the white matter, it doesn't matter that it didn't grow back. The other neurons can take over their job, but the neurons weren't totally destroyed, and so that was a good thing because the gray matter wasn't as affected as they thought. In looking at it, 100 years later, but anyway, so CNS fibers never regenerate. Okay, so here's what I want you to do between now and Monday, because I want this to be fairly familiar to you. I want you to go through the cranial nerves here and then read through what their functions are. So I would like you to look at, oh, you don't have this. Okay, I'm just doing it right now. And we'll just finish this. And then you can pause it and read it. Almost done. 11, 12. All right. That was lame. I'm so lame. I just don't even think what I'm doing. You do have this though, because I have in the modules or all of the PowerPoints, so you can take a look at that. But read through that. This chart that I have right here, and that's in your notes, this tests for dysfunction. So what that means is, what can't you do? So you think about, well, what can't you do? So what must it do? But we're gonna modify this so that we have, what the functions actually are. And you know what? I may put a document in the module about cranial nerve function. Yeah, I think I'll probably do that. But you also need to know this. You need to know the name of the nerve, what it is, whether it's a sensory nerve or it's a motor nerve or it's mixed, so that it's both sensory and motor, and where it goes and what it does. Boom. Okay, so that's where we'll end now. And so take a look at cranial nerves, get familiar with them, because you're going to need to know them for the test. So, all right, that should do that for today. Does anybody have any questions before we leave? And look at, you guys are so cute. You're always the same ones that come. I appreciate your 100% attendance since COVID-19, it seems like. So tell your friends, come to class. I guess, they didn't have anything to do this hour before COVID-19, so it'd be a good idea to come to class, but whatever, do what you can do. All right, so have a great weekend, and we'll see you on Monday. Bye.